Well, today I will guide you guys through what is the keratoconus screening software that we are using in the MS-39 and how artificial intelligence was included in the screening process of keratoconus. So first of all, we already know what is the MS-39. I will go through this slide a little bit quicker because you guys, most of us are acquainted with it. And the artificial neural network is the type of artificial intelligence that we use for the screening. So basically, you have to give the artificial neural network an input of parameters, and then in the middle will be a hidden layers that work similar to the human brain, and then it will generate an output that you will decide what will be. So it's a supervised machine learning type of neural network that we developed. We included 6,677 eyes that were collected in 3 different locations, Oman, Saudi Arabia, and in Spain, by Dr. Alal Dansuri, Jorge Alio, and myself. And we review and we agree on all of these 6,677 topographies, and we classify them between 4 different groups, actually 5 different groups, into normal cases, keratoconus, borderline cases, post-op myopia, and abnormal topographies. And we got into agreement to select all of the scans to have the agreement between the 3 of us. Then we used 70% of the data to train the neural network, and we left the remaining 30% of the data to confirm that the network was performing for validation of the results. This was done during the pandemic, so we had all the meetings through Zoom, and the result of this is this paper that you guys can scan here with the QR code if you are interested in knowing all the parameters and the indices that are included in this neural network. So I would like now, it's been a couple of talks and the people is a little bit tired now, so I would like that you guys get involved in the participation, and I would like to ask to raise the hand of the people who would perform LASIK or lenticle extraction in this topography. Just based on this, who will be performing LASIK?
Give us the prescription, because if it's a -3, yes.
This is, we're expecting to have a within normal limits prescription. So this is how the screening layout of keratoconus looks like. We have in the left all the anterior maps. Afterwards, we have the posterior, and then we have the epithelium and the stromal and corneal thickness maps. So we see that all the points are coincident, and they are showing us here that they are all having a very close relation to each other, and they are creating a white circle that looks quite small and falls where the majority of the cases with keratoconus should be expected to be. And the machine is clearly identifying that this is a borderline cases. Those were cases that previously with Sirius and Pentacam, we would have performed LASIK based on the 4 maps that I showed you before. I think Ivan is not convinced. I'm trying to convince you with the other cases. So this is the fellow eye, in case that there was a doubt that it was a keratoconus, in case that you guys thought that maybe we are giving too much power to the epithelial maps, but this is the fellow eye, so indeed the previous case was a keratoconus. So the input neurons can be anything. It can be pixels of an image, but when we use input layers, for example, the pixels of an image, we will need millions of topographies to be able to train the network. So what we did in our case, we pre-processed that, and part of the information was selecting inputs that were already indices that were significantly affected in keratoconus that we already knew were there. So what are the indices that we selected? This is all the indices that we selected in the left. And based on all of these inputs, all of these indices, we achieved the output that was these 5 classifications. So the input neurons, I will just tell you all of the indices part by part. So we started, as it was said, using the K-max values for anterior and posterior, but not based on axial or tangential maps. We use Gaussian maps. We also use the symmetry index that evaluates this 3 mm circle from the superior and the inferior with a certain angle for the right or the left eye, as you can see in the image. But this index was not enough for central keratoconus, nipple keratoconus. For this type of keratoconus, we use the central surrounded index. So it's basically evaluating the central 3 millimeters ring circle with a ring between 3 to 6 millimeters in the topography. So as I say, we use Gaussian curvature maps because Gaussian curvature maps are not based on only one meridian. Here it evaluates every single point in 2 meridians, and it hides all the astigmatic component that we have. As we can see here in this topography, everyone would agree in the past that the center of the keratoconus was that point that is shown in the posterior surface in the right. But when we see, this is a tangential map, but when we hide completely the astigmatic component in this patient, we see that the point is displaced to the real center of the keratoconus in this patient. So also we use indices of elevation. We use the most elevated point for the anterior and the posterior. We use the high order aberrations, and we use the ectatic index for the front and the back. That basically is the decomposition of the Cernic terms that are already known to be affected in keratoconus. Input neurons in thickness. Also we use the minimum thickness that is already well known. We use the symmetry index similar to the curvature with these 2 rings of 3 millimeters. And we use the thickness increase maximum not only for the total corneal thickness, but also for the epithelium. Similarly, the epithelial thickness increase is defined as the maximum increase in the epithelial thickness map. We already also use another index that is the notable points spread. So we selected 7 different points in the different maps, in the curvature maps, in the elevation maps, in the epithelial maps, in the stromal maps, and in the total corneal thickness maps, as we can see here. And all of these points are measured. We are going to measure the center of the spread of these points and how they are close to each other. So we measure the reciprocal distance in these points. In a patient with keratoconus, the reciprocal distance will be very close to each other. So it will give us a white circle, as you can see there, that is very small in the topography. And in a patient with a normal eye, not keratoconus, that white circle will be larger because the points are more spread. The central epithelium, the thinnest point of the epithelium is different from the steepest point, and all of them, they have a higher reciprocal distance. We always have 2 fixed rings, as you can see, the yellow and the red one. The yellow represents where 99% of the patients with keratoconus are expected to have the center of the keratoconus, and the red represents 95% of the patients with keratoconus are expected to have the center of the cone. So this classification, what we achieved with this classification. So previously, we had with the Sirius software, with the Sirius screening without using artificial intelligence, we have 97% of accuracy and 78% of accuracy that went up to 98.5 and 83.6 using now epithelial data and a neural network involved in our screening. So how the indices perform? You might want to know which are the best indices, which ones I want to pay closer attention. So the first 2 columns will show the difference in a keratoconus patient, real keratoconus patient, and a normal eye. So all the indices, as you see, are performing outstanding, excellent, as expected. It's very easy to differentiate a normal cornea than a real keratoconus cornea. But what happens when we are going to differentiate a normal cornea from a cornea that is suspicious? That is what we want to do, to screen for suspect cases and not to perform LASIK or refractive lenticle extraction. So the indices that achieve excellent discrimination are the ones that are highlighted, and this is also in the paper that we published for the neural network. So this is important to know, that the diagnosis that is going to be given by the device is just a guide for us. We need to involve the clinical part. As Ricardo was saying, we have to involve and decide if this is a real case. We have to evaluate more things in the patients. Perhaps we are in front of a scar, we are in front of something different. So it's not a main diagnosis that we have to rely on. I will show you another cases that I would like to have more participation, please. So in this one, how many of you would perform LASIK or lenticle extraction? Okay, 1, 2, 3, 4, 5. Okay. How about you guys?
I would need to see more.
Yeah, okay. But if you only have this information and it's a -2, so Ivan doesn't argue with the power of the correction.
If I don't have anything else, I would.
Okay. This is the treatment. So how about now, Farhad? What would you do in this case?
Can you put the values to it?
Oh, no, it's a photo.
Sorry?
It's a photo. I cannot, it's not the Phoenix 4.
So the epithelium is fit in the center?
So here he pointed out very well, we have a thinning in the area that we are expecting in the left eye, in the right eye, that the keratoconus might be happening. And the pattern deviation of the stromal thickness confirm that this is a case of keratoconus. Someone might say, no, not really convinced. Let's see the fellow eye. This is the fellow eye of the same patient. We see the same in all the maps, in the anterior maps, in the posterior maps, and also we see the pattern more clear in the epithelium, and the stromal pattern deviation maps and the corneal thickness pattern deviation maps are confirming, and the device was accurately identifying, as you see in the right, as a keratoconus case. Here we have another excellent tool, that is the enantiomorphism, that basically shows the right and the left eye in a mirror image to see all the maps and see the location. It's basically in a mirror, but in this case, because the keratoconus is different degrees, one more advanced than the other one, we can see the difference between one eye and the other one. Here is another case. How about this one? For here, I identify that there is a pattern already shown in the posterior maps that is also in concordance with the, so the posterior maps are already in relation with what we see in the epithelial maps and in the epithelial pattern deviation. Here is the fellow eye, and in the fellow eye is slightly more evident in the posterior maps and the epithelial maps, and confirm the diagnosis of keratoconus or keratoconus suspect. The device is also already, yeah, so it's already identifying. It's a much earlier stage than the previous one, but we already identified those signs that are guiding us to see that there was already something happening in that topography. So what Francesco is saying is that what we see in these three inferior maps is how this is deviating from the normality, from what we expect in a normal population. So is the pattern, how it deviates of what we expect in this patient to have the thinning or the area where the epithelium should be thinner in the topography. Here is another case. It's a case that I had done series before. In this case, the series looks absolutely normal in all the maps. Even the keratoconus screening looks quite normal for me. The left eye also of the same patient, the series looks normal, and all the maps in the keratoconus screening software of the series were absolutely normal. But then I performed an MS-39, and when I did the MS-39, I see what is going on. The epithelium is already showing, while the posterior is still not showing anything, and the pattern deviation of the stroma and the corneal thickness is already showing me, and it makes this patient fall into the diagnosis of keratoconus suspect. This is the fellow eye. That is a...
Can you go back? Because I see that the classification is normal.
Yes, the classification is not 100% accurate. As you saw the performance inaccuracy, yeah.
It's classified as normal.
It's classified as normal, and that's why it's very important. It's just a guide for us. We have to discriminate and decide based on what we see, but we are the ones who made the diagnosis, not the diagnostic device. This is so already very important that that's why I highlight in one of the previous slides. So this is the fellow eye. It's also evident, the epithelial pattern and the stromal and corneal thickness pattern deviations. Here we have another case. How about this one? I would like to have one of you telling me what they think about this case. So we already learned that we have this epithelium and we see the pattern similar to the other cases. Is this a case that, Ivan, you would like to do a smart site, lenticle extraction, for example? Yeah, but the epithelium is affected. How many of you say that we will not touch this patient, that it's already changes in the epithelium? Well, the epithelium is changing indeed, but the stromal and the corneal thickness pattern are absolutely normal. So this is not a patient of keratoconus. So changes in the epithelium are not equally to keratoconus also. We need to use all the maps to diagnose this. This patient, the epithelium is something that is changing daily. So this patient can come in a follow-up and have now the epithelium absolutely normal. So we need to pay attention of the evaluation of all the maps together. So here I want to show you guys another case, 2 more cases. This is a case where I agree that most of us wouldn't treat with LASIK or lenticle extraction. How many of you would do LASIK? Not really, yeah? It's not a case that I would like to do LASIK or lenticle extraction. But it's a patient that I did confocal microscopy, and I saw the patient have a corneal neuroma just in the area where we see that the epithelium is thicker and that the stroma was showing the elevation. So this patient, MS-39 is not only useful to exclude patients for refractive surgery, because many people will say, if I buy the MS-39, I will stop doing now LASIK. I will have to send all the patients for PRK or exclude them all for surgery. No, it also helps us to include patients of keratoconus. Here is another case. Here is another case that shows us something similar, a patient with blepharitis, patient that we wouldn't have done refractive surgery before, but it has an inferior epithelial hyperplasia due to the blepharitis in the right eye, as you can see, and in the left eye also the same inferior epithelial hyperplasia. The patient was treated with the blepharitis and had a smart side lenticle extraction without any issues. So, as I say, this has not changed the performance of our clinic. Now in red, we see all the surface treatments that we were doing in these cases of keratoconus suspect since 2020, and it has been consistent. So the MS-39 has not made any major changes on excluding more patients for femtolasic or lenticle extraction. In femtolasic, we see in green, we have a big drop in femtolasic cases that is being now compensated by the lenticle extraction because we are mainly doing the treatments now with a lenticle extraction. So I already have a topographer. What else can I do with MS-39? Just screen for keratoconus? No. It's useful also to decide where are we going to implant rings or KERS in the patients with keratoconus. We can use the different axes to decide where is going to be that bisecting line of the conus. And it has a very nice calculator that allows us to select where is going to be the incision, where is going to be positioned the ring, which diameter of implantation I want to decide to implant in these cases. I'm about to finish? Okay. So here is, similarly, we can see also the differential maps, the preoperative scans in the left, in the middle, the post-op, and the differential maps. And it's also helpful to measure the results in the patients when we do implant rings. Also with KERS, it's very useful for us to see the preoperative, the result that we achieve in those patients, and we also can measure the position of those KERS, where we implanted, how thick they are now in the cornea after the implantation, how wide was the tunnel, like we can measure here in this image, and try to correlate that with the effect, with the result that we achieve. In patients who had in the top LASIK in the past, in patients that we are able to tell now if that patient had PRK in the past or not, when we see in the left here absence of Bowman layer, and also in cases of rings to implant, are implanted to measure the depth of the implantation of the position. This is a very nice case of ectasia treated with intracorneal ring segments, and the scans have very high definition that allow us to see in red all the stroma of the flap, the position of the rings, in blue all the epithelium, and even is identifying in green in the top the tear film. And to measure, as it was mentioned before, the demarcation line in patients with cross-linking, and it's also useful for when we treat these patients of keratoconus, for example, this case that was treated with a ring and ICL, so we can also measure the volt in these patients. But remember that volt is not a fixed measurement. Volt is a dynamic measurement. How we can measure that? The MS-39 has a way that we can video and measure the volt in different light conditions. So we can clearly say if the volt is affected in different light conditions based on the changes in the pupil diameter with these light conditions. Thanks for your attention.